Okay, good morning everyone. So we are the eating disorder group. Before we start, we just wanted to let you know that our presentation contains trigger warning about self-harm, depression, and different kinds of eating disorders. So I'm Marianne Macan.
I'm Ronnie.
I'm Fabiana. I'm Lila.
Lord, the eating disorder.
So first, let's define what is eating disorder. So eating disorder is a mental disorder defined by abnormal eating behaviors that negatively affect a person's physical or mental health. It is said that one eating disorder can only be diagnosed at one time. Individuals with eating disorders is also having anxiety disorders, depression, and substance abuse. For the statistics, it is believed that 20 to 60% of patients with eating disorders is also having an OCD or obsession compulsive disorder, which is also tackled before with Sir Marco in Brain and Mind. And one of the remarkable features about each of the eating disorders is how persistent the diagnosed eating or dieting behavior becomes once it has begun. So eating disorders results in about 7,000 deaths a year as of 2010. So it is believed that anorexia has a risk of death that is increased about fivefold, with 20% of deaths as a result of suicide. And so for the rates of death in bulimia, it is said that it has about 2%, two-fold increase. So for the classifications, for our presentation, we will be just focusing about the two, the anorexia nervosa and the bulimia nervosa. We will be discussed later on this presentation. But to give you an overview, anorexia nervosa or AN is the fear of gaining weight. Even the individual has a underweight. Then bulimia nervosa is an individual is already having a normal weight, but this individual will binge eating but with purging afterwards. And then we have binge eating disorder or the BED. This is the individual with binge eating or the lost control of eating large amount of food but without the purging. Avoidant restrictive food intake disorder. This is the picky eaters or they have the lack of interest in eating. It is because of the smell of the food, color, or textures of the food. And the last one is the pika or paika. This is individuals is having a enjoyment in eating a non-item foods like hair, clay, or dirt. It is more common in children and pregnant people. So for the complications, we have acne, constipation because of the dehydration, osteoporosis, it's because of the low calcium intake, pellagra, which is the deficiency in vitamin B3, which is the niacin. So niacin is it helps to convert nutrients to energy. So eating disorders, individuals with eating disorder have fatigue also because of this. Amenorrhea or loss of menstruation, kidney failure, tooth loss, xerosis or dryness of skin or any membranes of the body, cardiac arrest, death, suicide, and electrolyte imbalance. For the causes, it is said that for genetics, an individual who is a first-degree relative of someone who has had or currently has an eating disorder is 7 to 12 times more likely to have an eating disorder themselves. For the psychological, as I've said a while ago, those who have anxiety disorders also have these eating disorders. We have personality traits, so there are various childhood personality traits associated with the development of eating disorders such as perfectionism and neuroticism. During adolescence, these traits may become intensified due to a variety of psychological and cultural influences. Those with celiac disease, so people with GI disorders may be at more risk of developing disorders rather than the general population because of the restrictive eating disorders. So in the fear of getting the gluten, so they are just avoiding some foods. And we have environmental influences, child abuse, social isolation. Because of the bullying and the abuse that they have, they seems to they have the comfort of eating foods. Parental influences, peer pressure, cultural pressure, and food insecurity. So for the food insecurity, it is because of inadequate access to food, both in terms of quality and quantity of food. So last, for the pathophysiology and mechanism, so it is believed that the HPA axis or the hypothalamus pituitary adrenal axis is having a significant component or having significant role in eating disorders. So what is HPA? HPA is hypothalamus pituitary adrenal axis is a combination of neuroendocrine system. So it is a set of complex feedback and influences between these three glands. So we have hypothalamus, which is part of our brain, which helps release hormones that controls our appetite. Then we also have pituitary, which is also found in our brain. It is also called as a master gland because it secretes the hormones in endocrine system. And lastly is the adrenals, which is found in our endocrine. It helps to regulate metabolism. So it is believed that this regulation or this dysfunction of this HPA axis has been associated with eating disorders such as irregular manufacture, amount, or transmission of certain neurotransmitters, hormones or neuropeptides, and amino acids such as homocysteine, elevated levels of which are found in anorexia and bulimia as well as depression.
Okay, so for the diagnosis, early detection and intervention can assure a better recovery and can improve. So in the past 30 years, eating disorders have become increasingly conspicuous and it is uncertain whether the changes in presentation reflect an actual increase. Anorexia nervosa and bulimia nervosa are the most clearly defined subgroups of a wider range of eating disorders. So neuroimaging using fMRI, MRI, PET, and SPECT scans have been used to detect cases in which a lesion, tumor, or other organic condition has been either the sole causative or contributory factor in an eating disorder. So for the psychological, after ruling out organic causes and the initial diagnosis of an eating disorder being made by a medical professional, a trained mental health professional aids in the assessment and treatment of the underlying psychological components of the eating disorder and any comorbid psychological conditions. And in differential diagnosis, there are multiple medical conditions which may be misdiagnosed as a primary psychiatric disorder, complicating or delaying treatment. These may also have a synergistic effect on conditions which mimic an eating disorder or on a properly diagnosed eating disorder. For example, Lyme's disease, gastrointestinal disease, Addison's disease, which was discussed earlier, and gastric adenocarcinoma. So for the prevention, we have emotional bites, saying no to teasing, body talk, and fitness comes in all sizes. So first for the emotional bites, it is a simple way to discuss emotional eating. A simple way to discuss emotional eating is to ask children about why they might eat besides being hungry. So we should talk more about effective ways to cope with emotions, emphasizing the value of sharing feelings with a trusted adult. So saying no to teasing is pretty self-explanatory. Another concept is to emphasize that it is wrong to say hurtful things about other people's body sizes. And for body talk, it emphasizes the importance of listening to one's body, that is, eating when you are hungry and stopping when you are satisfied. Children intuitively grasp these concepts. So lastly, in fitness comes in all sizes. It is important to educate children about the genetics of body size and the normal changes occurring in the body. It is important to discuss their fears and hopes about growing bigger and focus on fitness and a balanced diet. So for the treatment varies according to type and severity of eating disorder, and often more than one treatment option is utilized. Various forms of cognitive behavioral therapy have been developed for eating disorders and found to be useful. If a person is experiencing comorbidity between an eating disorder and OCD, exposure and response prevention coupled with weight restoration and serotonin reuptake inhibitors has proven most effective. So other forms of psychotherapies can also be useful, such as cognitive behavioral therapy or CBT, which postulates that an individual's feelings and behaviors are caused by their own thoughts instead of external stimuli such as other people, situations, or events. Next is the monthly anorexia nervosa treatment for adults, or MANTRA for short, which focuses on addressing rigid information processing styles, emotional avoidance, pro-anorectic beliefs, and difficulties with interpersonal relationships. So these 4 targets of treatment are proposed to be core maintenance factors within the cognitive interpersonal maintenance model of anorexia nervosa. And we have behavioral therapy focusing on gaining control and changing unwanted behaviors, as well as cognitive emotional behavior therapy or CEBT, as well as art therapy, nutrition counseling, and medical nutrition therapy, which are pretty self-explanatory, and self-help and guided self-help, which includes support groups and self-help groups such as Eating Disorders Anonymous and Overeaters Anonymous. Having meaningful relationships is often a way to recover. For the medication, olanzapine seems to promote weight gain as well as the ability to ameliorate obsessional behaviors concerning weight gain. Zinc supplements have been shown to be helpful as well, and cortisol is also being investigated. So another 2 pharmaceuticals, Prozac and Vyvanse, have been approved by the FDA to treat bulimia nervosa and binge eating disorder, respectively. Olanzapine has also been used off-label to treat anorexia nervosa.
So I'm gonna discuss about anorexia nervosa. This is an eating disorder characterized by low weight, food restriction, body image disturbance, fear of gaining weight, and an overpowering desire to be thin. This is the term Greek origin, and anorexis translating literally to a loss of appetite. For the nervosa, this is indicating the functional and non-organic nature of the disorder. So, anorexia nervosa, coined by Gall in 1873, despite literal translation, the feeling of hunger is frequently present, and the pathological control of this instinct is a source of satisfaction for the patient. Individuals with anorexia nervosa also often deny that they have a problem with low weight. So two types of anorexia nervosa is binge eating or purging type, and then the restricting type. So when we say the binge eating or purging type, patients with anorexia could show binge eating and purging behavior. It is a different from bulimia nervosa in terms of the individual weights. An individual with binge eating purging type anorexia is usually significantly underweight. People with bulimia nervosa, on the other hand, can sometimes be normal weight and overweight. For the restricting type, the individual use restricting food intake, fasting, diet pills, or exercise as a means for losing weight. They may exercise excessively to keep off weight or prevent weight gain, and some individuals eat only enough to stay alive. In the restricting type, there are no recurrent episodes of binge eating or purging present. So for the signs and symptoms, we have the hypokalemia, which is the low potassium level, the blood. Physically, anorexia nervosa have low body mass index for one's age and height. Amenorrhea, or the means loss of menstruation, dry hair and skin, fear of weight gain, rapid and continuous weight loss, or lanugo. This is a soft, fine hair growing over the face and body. This is it could be seen when you to the childbirth. Bradycardia and tachycardia, fatigue, and hypotension. And then cognitively, anorexia nervosa, obsession with counting calories and monitoring the fat contents of food, preoccupation with food recipes or cooking, admiration of thinner people, thoughts of being fat or not thin enough, altered mental representation of one's body, poor self-esteem, perfectionism. So, and then effectively, anorexia nervosa have depression, ashamed of oneself or one's body, anxiety disorder, or rapid mood swings and emotional dysregulation. And behaviorally, anorexia nervosa have food and energy restrictions, food rituals, purging with laxatives, diet pills, and ipecac syrup or diuretic. Ipecac syrup, this is the emergency treatment of certain kinds of poisoning. For example, if you are poisoned, you will use this to vomit the poison. Excessive exercise, self-harm or self-loathing, or dramatic weight loss, and then refuse to eat certain foods, like for example, no carbohydrates, and then makes frequent comments about feeling fat or overweight despite weight loss. So, for the diagnostic criteria for anorexia nervosa, there are three restriction of this is all of which needing to be met for diagnosis. For the criteria E, restriction of energy intake relative to requirement leading to low body weight. For the criterion B, intense fear of gaining weight of persistent behaviors that interfere with gaining weight. For the criterion C, disturbance in the way of person's weight or body shape in experience or a lack of recognition about the risk of the low body weight. So for the body mass index is used by the for the treatment. For anorexia nervosa tries to address three main areas. This is restoring the persons to a healthy weight. So for the goals of anorexia nervosa, to increase weight to 90% of average body weight, and then treating the psychological disorder related to the illness. So for the goal for this, we need to increase the self-esteem of the patient, then reducing or eliminating behaviors or thoughts that originally lead to the disordered eating. So for the role of the PSW, monitor weight before meals, monitor intake and output, monitor food intake, especially calorie intake, stay with the resident during meals and after an hour, help client identify triggers, exercise policy, make sure that the client is eating 3 times per day, make sure to do not skip meals, make sure that the resident is taking the meals and not packeting only. Then encourage and reinforce healthy diet to gain weight.
I'm going to discuss about the bulimia nervosa. It's an early eating disorder characterized by binge eating followed by purging or fasting, and excessive concern with body shape and weight. The aim of this activity is to expel the body of calories eaten from the binging phase of the process. Bulimia is frequently associated with other mental disorders such as depression, anxiety, borderline personality disorder, bipolar disorder, and problems with drugs or alcohol. So the signs of symptoms are chronic gastric reflux after eating, dehydration and hypokalemia, electrolyte imbalance, esophagitis or inflammation of the esophagus, Mallory-Weiss tears, which is the Mallory-Weiss tears is a tear at the tissue of your lower esophagus caused by violent coughing or vomiting. Oral trauma, Russell signs are the calluses on knuckles and back of hands due to repeated trauma from seizures. Signs and symptoms. The signs and symptoms are the gastroparesis, delayed gastric emptying, constipation or diarrhea, tachycardia or palpitation, hypotension, peptic ulcers, infertility, constant weight fluctuation, hypoglycemia may occur after vomiting. The diagnostic criteria utilized by DSM-5 includes repetitive episodes of binge eating compensated by excessive or inappropriate measures taken to avoid gaining weight. The role of the PSW are to monitor the residents 1 to 2 hours after each meal, one-on-one supervision, monitor fluid intake, output, check for hidden binge or purging, check for hidden trash food wrappers, check for hidden laxative at bedside or food dairy. So those are our references.
Any questions from the audience? That's well covered, right? Very well covered. Yeah, both types. I remember working with students on psychiatric unit at F Maine on the Civic Hospital.